Good morning. Great. Good morning. So it's my pleasure to introduce Aneesh Chopra. We're going to have a conversation about digital health and innovation. Aneesh is president of Journey, and that's an organization that helps providers and payers and pharmaceutical companies. But his background, he was the first US CTO under the Obama administration. And before that, you were Chief Technology Officer of Virginia, correct? Great. So Aneesh, we just had a great conversation with Peggy and Jonathan. We were talking about that backstage. Would you like to continue and respond to that conversation?
I did. So let me just, first of all, great to hear John this morning. John and I were classmates at the Kennedy School, so it's kind of fun to see a life together. You heard in the question about the visit to the ACOs and the dialogue about what was care coordination supposed to be like and what are the rules that are on the books and what is it like on the ground. I want to take a moment at the front end of this to sort of, it's a theme we're going to cover throughout this morning's session. We need to complete the circle from the supply of standards and data infrastructure and the demand and use to demonstrate the value. And here's an example. I refer to this as we failed to land the triple axle. And so when we first wrote the meaningful use rules, and I saw John Glasser earlier, grateful to the Godfather for his guidance, we had an objective, which was to make the system move from paper to digital, but also to prepare for a shift in the policy towards more coordinated care, value-based care, population health. These were dual objectives. And so as we contemplated the definition of meaningful use, there was an anticipation that what was valued in the market at the time in fee-for-service may not be that which we wanted to further incentivize, but if we could shift the underlying capabilities, even if the market wasn't ready to demand some of those features, that we could land a triple axle by getting the demand signal to catch up after the first rounds of subsidies, so that by the time we moved from subsidy to kind of accountability, the market would see value and we would move forward. This is one small example where we have failed in that triple axle. So it is currently CMS policy that every single hospital provision an admissions discharge transfer feed to a patient or an entity that is designated by the patient, or to a physician for whom that patient's care is responsible. That is written in not only generic regulation, it's in the conditions of participation. In other words, failure to honor that care coordination step meant that you have a risk that you could stop treating Medicare patients. Yet, years after this codification of a rule, I am shocked at how little public options there are. Meaning, doctors today still don't get these feeds. Everyone is dependent on a vendor to whom they pay a fee to sort of hopefully get access to a network of ADT feeds. And I said, this rule was the opposite. A doctor should go to the local hospital and say, here's my list of patients. They should have the capacity to administer that list and to administer this program. Failure to do so would violate this rule. Yet I'm shocked, 2023, has any ACO or any physician group in the room asked a local hospital for their ADT feed directly without having to go through a vendor middleman? Let the record show there's not a single show of hands. And when I asked the hospitals, they said, no one's ever asked. That can't be true. But whatever, the demand signal has missed. So here's one where this is like frustrating at every level. The standards are clear. This is not thing that requires some future AI, dreaming of the blockchain or something crazy. This is relatively simple feed that's got a clear policy requirement. And in the real world, it doesn't flow. So that's a little bit about what we're going to talk about today. Yeah. We're going to move from the supply side. We have to put emphasis on the demand side, and we got to shine light. First of all, we have to let people try. And if they can't succeed, we need to enforce actions so we can demonstrate that these rules mean something.
So Jonathan spoke about some of the foundational or infrastructure challenges. One of the regulations, we're referring to it as G10, and the bulk fire capability. You want to just enlighten everyone about what the regulation or the mandate is?
Yes. So if we go back in time, meaningful use was a three-part harmony. What our godfather David Blumenthal used to say was like an escalator. You'd start from the base, you go to the middle, you get to the top. And by the end of that escalator metaphor, we had put in place the 2015 rules that said the consumer was entitled to basically application access to their health information. And that's what began the journey on the Fire API. The consumer's functional right to connect an app of his or her choice to an EHR system and to be able to extract a standardized set of data elements. That Fire API, consumer-facing, was seen as like, okay, that's a consumer thing, and then for all the other use cases in healthcare, we're going to stay with the crappy B2B manual hand cranking and data conversion life that we live in. Congress, in a massively bipartisan manner, 2016, passed the Cures Act. And President Obama signed it. President Trump wrote the regs, and President Biden gets to oversee its implementation. Massively bipartisan. And the argument was, Fire APIs, or in this case, APIs, not saying Fire, APIs shall be the foundation for data sharing. This is a massive sea change from the current clearinghouse-based EDI transaction model of healthcare. This basically allows for internet-style application development. And so the one missing technical gap at the time was what's the B2B version? There are only two flavors of Fire that were in the real world up until the G10 server. The first one was the consumer access, but the second one was what I refer to call the all-you-can-eat buffet. And the all-you-can-eat buffet means that if I give a key to you, Ed, if I'm a hospital, and I give you my all-you-can-eat buffet key, you could query for every single patient in my back-end system. Not a lot of security officers feel comfortable giving you the all-you-can-eat buffet key because I have to trust that you're only going to query for people for whom you are entitled to pull the information. And so theoretically, we'd have a middleman that would do that kind of trust framework, and we're getting there with TEFCA. But in the short run, it's not comfortable to go from single patient unlocking it themselves to all-you-can-eat buffet. So a compromise middleware capability came in, which is called G10 Bulk Fire Server. And the theory was EHR vendors and now health plans both have the technical ability to constrain the key that I give to Ed to just a limited set of populations. It could be my ACO attribution list. It could be health plan A's members. It could be COVID positive patients. It could be any criteria, clinical, administrative, or otherwise. And that allows you to construct a filtered key, and that filtered key gives you more freedom to query for that population, but I'm confident you're legally entitled to all of them. That requirement, thanks to the Cures Act, went live December 31 as of last year. As of the spring, about 290 certified EHRs demonstrated that they could deliver this functionality, certified it, and made it available to their customers. And thanks to Jonathan's rules on, basically the physician fee schedule, all doctors and hospitals had to turn this feature on October 3rd for the last 90-day reporting period. So in theory, right now, the majority of doctors and hospitals in America have the ability to exercise this filtered export for purposes of any use case deemed worthy by contract. And that's an exciting proposition. Where we're going to go next is the unfortunate reality, which is raise your hand if any, do anyone here have a certified G10 Fire server inside their enterprise? Just kind of curious if I could see a show of hands.
Ooh, one.
Okay, good. And then I guess the uncomfortable question would be, have you used it for anything? We're now October, and the volumes of use, I can count on one hand the number of organizations that have publicly spoken about actually using it. By the way, it's all culture and training. There's no training manual. There's no like easy button, like how do I configure this key and how do I share it? And does the systems make sure that it's used appropriately.
This is one of the ways that NCQA is trying to assist CMS in these foundational infrastructure challenges. So as we have digital measures, and I'm sure you've been hearing about our digital measure efforts and how quickly we've been able to get our 77 HEDIS measures now encoded in CQL. What's foundational for that is we need clinical data to support that. So we are, with Aneesh's help, rolling out a bulk fire data quality coalition to really test the validity of these bulk fire G10 endpoints. Ken Mandel did some great work up at Boston Children's Hospital. There's a great paper out there that I encourage you to read. It shows the performance of these endpoints. Performance is shaky, but what Ken isn't able to do is discuss how good the data is. Is the data high quality? Is it, the API may work, and that's what he's testing, but it may be full of nulls. This coalition will run these data sets against our HEDIS implementation guide and validate against our HEDIS data. We're also planning to have 3 individual measures and individual measure implementation guides, so we can say it works for the depression measure. It does not work for high blood pressure or A1C. We'll be able to have some specifics. And the idea behind this is we can then arm CMS and ONC with real data, because we have a use case for this G10 endpoint. We want our HEDIS measures to become ubiquitous, and to do that requires good quality clinical data in bulk.
Let's just pause for a minute. He said that exactly by the book, but I want you to understand how important this is. Today, NCQA is announcing that it will support a group of voluntary coalition of the willing to demonstrate the viability of this infrastructure to modernize the way we run quality. We can move past the days of quality as an after the year is done sampling report to give us a scorecard, to a world where my mom and dad on Medicare can have a real-time availability when they access the patient access API with the clinical data and the claims data held by the plan to run their own quality scorecard. Are my mom and dad getting the quality of care they deserve? It's frustrating as the son who's been in this industry for a long time not to give a great answer to that question. Intuitively, I'm like, God, there's a lot of gaps in the system. But I want to be equipped with the knowledge. If she were to be evaluated against any of these HEDIS measures, how would she score? So in order to get there, we need you. I am grateful that NCQA has stepped up to the plate, not required to do this, not forced to do this. But boy, oh boy, are we grateful as a system that NCQA is creating a community to learn together. Because yes, Ken Mandel wrote a paper, who's the guru who basically wrote the protocol for the G10 Fire server. This real world evidence in this coalition's work will likely share the good, the bad, and ugly in the current deployments of the software. But that's okay. That's a feature, not a bug. Because everybody likes feedback. I'm on email threads with the EHR vendors. Epic and Cerner, and then a HIE homegrown version were the subject of this paper. And all of the emails were like, thank you for the feedback. We know now how to make it better. There's no evil empire. There's no, I'm going to actively make this thing suck. People just want to learn and get the feedback and do better. By the way, that's the power of the internet. Internet standards are exactly this agile, iterative process. There's no like Moses tablet and then we live off of that for 100 years. Obviously, we will learn and improve. So the premise right now is, if we all agree we want to move to the point where we can run daily HEDIS on our entire population, as Euban Park from Apollo Med noted yesterday, if you guys were here, we should aspire to do so in a cost-effective way. And this coalition will allow us to do it. So I will ask, first of all, Apollo Med's in the house. Can you raise your hand? Will you sign up to be a part of this coalition? Can I put you on the spot? Let me see the show of hands. Okay, yep, there they are. You're in. Okay. Are others in this room willing to stand up and say, we want to be a part of this coalition? No? I'm not going to quote you all, but I just want to see if there's any demand signal in the room. I see hands. I see hands. Do I see any more hands? I see plenty of hands.
Wonderful.
We only need a half a dozen of us to demonstrate what works, to give feedback to the system. And I thank you all for that. Ed, we want to give Amol a shout out, or how do you want to do next steps?
Additionally, tomorrow there's going to be a session where we're talking about more standards. So we have digitized HEDIS. We have 77 measures now written in CQL. They operate on a CQL engine that NCQA has developed, and we have now open sourced. We are trying to drive standardization for CQL engines to enable choice and confidence in engines. We do not want a black box solution. So to do this, we have a data quality implementers community being formed to standardize the math that CQL engines do.
The DQuick.
The DQuick. So the way I explain this is last year, my daughter, when she was in 7th grade, came to me and said, I need a scientific calculator. Well, you can go onto Amazon, and there are about 35 different vendors of scientific calculators. Who ensures that they're all calculating cosine correctly? Well, that's the challenge. And the challenge we have with CQL is it's a very new language. It's a very immature language. It hasn't had the years of maturity and development to standardize a lot of issues. So there are basic questions on the math. We, in this community, are going to be standardizing across any CQL engine provider, creator. So,
or provocatively, if it may be easier to run in Python.
These are all things that we need to explore. So I encourage you to go to the session tomorrow with Amal Vyas, our VP of Interoperability. There'll be others on stage that are signing up to be part of this CQL engine community to drive the standards on the calculation engine.
And let me just describe a little bit of the current state so you have a sense for the tidal wave of happiness that's coming. So the VA announced about a week and a half ago that 13 health systems have voluntarily agreed to open up their G10 Fire servers for the VA, and among the use cases is the calculation of quality measurement. So we're already in a sea of goodwill voluntarily, no grant funded, no need for subsidy, no need for third-party vendors. You have the infrastructure. And by the way, for the health plans in the room, you got to do the same thing on the physician access API. You've got to create a bulk fire server so that you can take that same patient access API from a couple years ago and make that available to groups of patients attributed to a doctor, health system, and ACO. So the reality is we're all going to learn together as a consumer of the data and as the supplier of the data. And I hope these engines that Ed is describing will take both of those feeds and demonstrate we can run the calculations more rapidly. So I am very excited about where we're heading and eager to dive into the dialogue. And if any of you can't reach Amol, find me, find Ed. We should all come together and demonstrate that this is something that can work, and we should do this measured in months, not years.
Great. Aneesh, where do you see other foundational challenges in this digital transition that the industry is going through?
So this is a little bit of the conversation that I was just having earlier with the landing of the triple axle. The reality is the supply side and the demand side are not on the same page. So we need to clean up a little bit about the rules of the road so that we all have one common approach. I think probably the most obvious example of this is there's a proposed rule, two proposed rules on prior authorization. One is the attachments rule that runs through the traditional clearinghouse systems, and the other is sort of the FHIR-based approach that's more of an application logic layer. And so you see this problem, which is that we've been building policy on use cases, assuming technology from a decade ago, 2, 3 decades. And so we're still kind of requiring that infrastructure be deployed, when in reality, if we had a functional requirement and had room for the industry to make adjustments, the highest and best use of the technology may naturally flow to regulated standards.
Okay.
So we have consistency. So my focus in the near term on this infrastructure question is to better align the demand signal with the supply and to work off of a regulated fire standards first approach. I think this is one of the challenges for the audience to pay attention to. Squares, rectangles. Fire is a rectangle. Anything under the sun can be written up as a fire implementation guide. It's like a happy place. I've got an idea, so I want a fire IG, and you have a fire IG, and I can have a fire IG, and there can be a million of them. The square are the two bedrock fire IGs that are required and regulated. The ONC rule, that is a fire API that delivers the US core data elements for interoperability. That bedrock is a square. That's the clinical square. And I'll call it the patient access API, which the plans had to administer 2 years ago, July. That's the square. So you've got two squares. What we must do, MacGyver style, is build our data sharing applications on the foundation of the squares. That allows us to see the savings.
Okay.
When we're sort of running around on different places of the world, then we've got a lot of, hey, it's fire, it's magic, it's supposed to solve everything. No, fire doesn't solve anything. It's just another language. It just happens to run on the internet. It is the regulated standards that say blood pressure coming off of EHR1 is going to look the same as blood pressure coming off of the EHR2. And I don't need to have a vendor in the middle to clean it all up. That is the square. And that's where you get savings.
Great. We have a couple of minutes left. If there are any questions for me or for Aneesh, please go up to one of the microphones. As you can see through this presentation and others you'll hear this week, NCQA is trying to work on these foundational challenges and move forward the industry in order to enable digital quality measures.
While we wait, if anyone does want to come up to the mics, feel free to do so. Let me just share a couple perspectives on how can is the square fixed or can the square grow? The answer is squares can grow. So let me give you a couple of examples. We're in the middle of a dialogue around cancer data. Right now, cancer stage is not in the square. The president's #1 personal priority in this area is the cancer moonshot. It is my personal voluntary goal to deliver for the president an expansion of the square to include cancer data elements. It would be criminal for me personally if I'm not able to help work with the community to deliver to the president what I think is deeply personal to him. And here's an example. CMS has put up a mandate for 15 or so cancer data elements for clinics that are in the oncology model, EOM. And their first reporting period is October of 2024. I believe we could do the same thing as the NCQA dialogue for cancer data to expand the square to include cancer data elements. Of course, I'd love to have you involved in that too.
Yep.
So this is an opportunity. Let's work together to build on these capabilities so we can expand. Yes, please.
Hi, thank you so much for your extremely insightful comments on this. I'm Antara, I'm from Innovasor. It's a data platform that also supports interoperability. So we worked, with a number of health plans and implementing the Fire data platform for patient access and so on. And what we found is that payers were not really valuing this because, it's called the patient access rule. It's meant to empower patients to access their data, but there was no mandate on education of the availability of this data, and therefore no adoption or usage. There's still extremely low usage of this, and this has been around for a couple of years. So do you have any comments on the direction this is going to take?
I know we're at time. Let me just make the obvious statement. Number one, I believe that Fire data infrastructure for patient access API will be the operating system for health plans. And any health plan that doesn't see it that way will find 2 years from now, oh my goodness, why don't we have this? And the reason is the same thing that CMS went through. The consumer-facing Blue Button API got some usage, okay? 85 apps, but the volumes are not reported, but I would say modest. But they turned on a physician access API using the same infrastructure as the patient access API. And there are thousands of developers helping doctors and ACOs make use of it, including, by the way, Care Journey is in there helping build apps because in the B2B model, there's economics around that. And the consumer model, we need consumer internet services that don't have an economic model. So right now, if you don't realize that patient access API equals physician access API with basically G10 servers, you're going to rebuild everything if you blew off this requirement. And that's going to be a big burden for you if you want to succeed in value-based care. So no, I don't think we need a campaign to fund education about the use of the patient access API. I'm glad it exists. And there will be, at some point, Apple will turn on an insurance API connector. And the minute they do, my mom and dad are going to be on it. And I'm not worried about it. Apple hasn't decided to do that yet. When they do, I can't wait. Samsung announced the HLTH. It will ship that natively in the next version of Samsung. So as Samsung and Apple duke it out, everyone is going to have a free app on their phone that will connect to each of your APIs. It will work, okay? No education needed. It's the next round. It's going to be critical. So I hope that message is loud and clear. You got to have a strategy for data sharing if we're going to be successful in what John Blum said earlier with Peggy on moving towards a coordinated experience.
Well, thank you, Aneesh. It is now time for the concurrent sessions. I will make a plug-in. Aneesh is going to be up on stage again here for the concurrent session. But thank you, audience. And please enjoy the concurrent session.
Thanks, everybody.